So welcome if you're arriving. We are recording the session just so you're aware. I just want to quickly highlight the aims of today's session. Really, we're about sharing some learning, some of the work that's been going on around the National Diabetes Prevention Programme. We want to support quality conversations and we want to share good practice examples. So there will be a resource that you can access following this webinar, as well as those evidence-based resources within the toolkit. So welcome, everyone. I'm going to hand over to my colleague, Dr. Caroline Gibson, who's going to give us an overview of some of the best practice in the field in terms of health coaching and diabetes. So over to you, Caroline.
Thank you, David. I'm hoping that you can all see my slides now.
Yep.
And David's nodding at me, which is always a positive start. Excellent. I'm going to talk very briefly, David said I could have 10 minutes just to speak about why health coaching and personalised care roles in general are really so important for people living with diabetes. And so I thought I'd start with just speaking a little bit about what I see as the problem. And why we need all you guys working in the personalised care roles to help look after these patients with diabetes. So diabetes care, it looks something like this, that your patients go and see the doctor or the diabetic nurse in the surgery, and we ask them how are they feeling. But what happens with our patients before they even come to see us as GPs, they've gone to have their blood tests, they've gone to have some investigations, and by the time they get to us as GPs or nurses, they kind of already got stuck in this medical model of blood tests and medications. And so when I ask a patient how they're feeling, they often tell me about their medications or their problems that they're having with getting their blood sugars right, and this is where we get very interested in. And science has evolved fantastically with looking after diabetic care from in the last however many years, and we've got a really good, strong evidence base for how we should look after our patients. So we kind of know what we are, we have this evidence that tells us what the best practice might be. And this has given us guidelines to work to. And so this is taken from the type 2 diabetic management. But as you can see, it's awfully very much medical model heavily. We're very much individualized care is the first thing on the list, but after that it's very much straight into blood sugar levels and HbA1c targets and drug treatments and more drug treatments and managing complications. And even when you sort of drill down into this a little bit more deeply, even when it talks about individualized care, it's still talking about medications and polypharmacy. Now, I don't know about you, but last time I asked a patient what would help you feel better, it's not getting my medications right is usually not the answer. So, and then the other thing that really doesn't help with looking after diabetic care is how general practice is set up, that we get very concerned about targets and meeting QOF and payments like this. And as you can see, the targets again here are all focused around medications and numbers and blood pressure readings and HbA1c readings. And I'm yet to have a patient come and say, doctor, I feel so much better because my HbA1c is down 2 points. It just doesn't happen. What we need to be doing is actually helping patients to feel better. So as I said, when I sit in my clinic, people often tell me medical things, but if I just want to ask you the question now, I want you to answer the question, how are you feeling? Because what actually makes you feel, what affects how you're feeling? So how are you feeling? So if I ask myself that question now, and if anyone knows me and works with me, the standard answer that anyone will get from me when you say, oh, how are you feeling today, Caroline, will be, oh my God, I'm so busy. I've got a zillion and one emails. I've got Teams meetings coming out of my ears. I am spending all my time staring at a computer. Oh, and also I've got to run away because I've got to pick the children up from school. I've got to go and take my dad to the hospital. I have got to do some exercise today. But that's me, and all of these things are affecting how I'm feeling. Other things that affect how we're feeling is, have we had enough time to relax? I am feeling reasonably good today because I've just had a holiday. I've had some time in nature. I have been out in the mountains for 2 weeks and it's great to be back. But unfortunately, I've come back off holiday and I've already got 101 emails in my email box. Actually, it's 157. So my brain is very, very active. I've got a high cognitive load today. I feel a little bit like I'm an NHS puppet on a string. And I am already beginning to feel my stress levels rise because I'm juggling summer holidays for the children and work. Also, I'm neurodivergent. My brain works in a funny way, but that's just part of what I'm like. Other things that affect how I feel, my genetics has a say, and that's the same for everybody, but it doesn't really affect me on a day-to-day basis. Other things that affect how I feel, I don't smoke, but occasionally I do have a glass of wine. I haven't had too much recently, but I might have done whilst I was on holiday, overindulged once or twice, but that's not having too much of an effect today. But it's sort of the sort of thing that we need to think about. What I eat, whether I'm hungry today, whether I have got to the hangry point. I haven't quite got to hangry today, but I haven't maybe eaten as well as I should. I might have had too much caffeine, which is why I'm talking too fast. And I know that David doesn't want me to run too late, but I am well hydrated today. I have had enough sleep, which is unusual, but everyone was really tired after a long journey home from holidays. So I was lucky that I didn't get woken up by the kids last night. Other things that might affect how I feel, have I had an infection recently? Luckily, not too recently. Other health conditions might be affecting how I feel. All the medications that I might take are having an effect on how I feel. Where I live, my housing, and the weather outside are things that might be affecting how I feel. So why am I talking about this? So all of these things affect how I feel and what I might describe as my symptoms on any one given day. But most of the time, our patients don't tell us about all these hundreds of thousands of things that might be having an effect. But we can sort of summarize these and make it look a little bit more easy to remember in this way. And I kind of like this kind of symptom wheel about things that affect how we feel. And it sounds really logical when we say that, like that, about how am I feeling, all of these things that might be affecting how I'm feeling. But actually, science is just about catching up with us now, and we can put mechanisms and reasons behind why all of those things that I've just listed about what's affecting how I feel today into some science. You know, I don't have time to go through each one in turn of all the 27 different things that are affecting how I'm feeling, but I could do, if I had a whole day to talk to you, I could talk about the microbiome and our epigenetics and our autonomic dysfunction and the balance and chronic inflammation and all of the reasons that all the lifestyle things have a effect on us. But for now, I think I'm just going to have to skip over it. You're going to have to trust me. But at some time I will come back and we can talk about why all these lifestyle things have such a huge effect and how it all leads into how we feel, but also directly into diabetes. So when we put it in so as I said right at the beginning, we get very stuck in this biological medical model with diabetic care, but actually all of those other bits, the stress levels, our sleep, our nutrition, our diet, our activity levels, our genetics, all of those things, and the environment around us, all of those wider things are all at play for diabetic care. So where do we come in as personalised care roles? So if we've got think about those main 8 areas that in lifestyle, this is where we can actually have a really huge impact. So for example, I am a health coach, and we can health coaches can work in all of these areas directly. Our social prescribing colleagues can have a similar really broad area of reach, and our care coordinators similarly. So our challenge as personalised care roles is to find out what's actually causing our patients to feel better and what's affecting how they feel. It's not just medications, it's not just the guidelines, it is the whole person approach. And that's why it is so important that you guys are involved in diabetic care. There you go. And that's me in a nutshell. I'm going to hand back to David.
Excellent, and thank you so much for helping to set the context there, Caroline, especially after you've just come back from holiday. And breathe. I think that's the next thing to say, and breathe. Well done. So we have our next speaker really, sharing some insights in terms of the work that's really behind all of this in terms of the pilot. So we've got Elaine Doula and Paul Rudd, who really are going to lead this next section for us. We'll spend some time hearing about the toolkit. Then we want to go into some breakout rooms. So there'll be an opportunity for you guys to tell us a little bit about your experiences and just to understand how we might use this opportunity going forward. So really over to you, Elaine and Paul. Thanks very much.
Hi, everybody. Thank you for that, Caroline. Absolutely perfect introduction for what we're about to talk about today. I'm Elaine. I was a care coordinator in a PCN in Wakefield and moved over to West Yorkshire ICB last year as a project manager in diabetes, and it's been really interesting to see behind the scenes of what we do on the front line and why that we do it. I used to work with Paul. I'll let him introduce himself.
Hi everyone, so some of you might know me. My name is Paul Rudd. I'm a health and wellbeing coach, team leader based in Wakefield for Trinity Health Group PCN. And funnily enough, when I started, I think it was about a few months later than Elaine left. Might be a bit of a correlation there, not causation, I'm sure. But yeah, happy to share this afternoon with you guys.
Fabulous. So what we want to talk to you about is the National Diabetes Prevention Programme. It is everywhere. We have Reed Wellbeing, our provider in West Yorkshire, may be slightly different in other areas. So just a caveat here that everything I'm sharing is based on West Yorkshire and there may be slight differences, but the key message is that this is available to everyone across nationally. So if you'd like to move to the first slide, please. Thank you. So a little bit about pre-diabetes. Now, I'm not clinical, so I have kept it as easy to understand as possible. And essentially, pre-diabetes is when your blood sugar levels are between the numbers of 42 and 47, which you would find out after a HbA1c blood test. Usually these are first done in a health check, maybe at the age of 40, you have your NHS health check, unless you've got symptoms, which would mean that it's done earlier. But a lot of the time it is symptom free, so it won't be picked up until that health check when you're 40 or the first time that you go to see your doctors. There is approximately 7 million people in the UK with pre-diabetes, and you are more than 15 times more likely to get diabetes type 2 if you have pre-diabetes. So we've seen the signs recently that there's 5 million cases of type 2 in the UK, and obviously it's just going to go up. So the best thing we can do is try and prevent it from happening in the first place, and that is where the National Diabetes Prevention Programme comes in. There is a number of factors, some of the things you can't change. So you've got family, history, ethnicity, age as a factor, which we can't do anything about. But then lifestyle factors have a huge influence on this as well. And these are the things that we can change. So even if someone thinks, I'm going to get it anyway, it runs in my family, they can try and prevent it by changing the lifestyle. And there's, options out there to help them do that. Do you want to move on for me, David? Thank you. So in West Yorkshire, some insights here. We have 132,000 people just in our county that have the pre-diabetic blood results, and these could be eligible for the National Diabetes Prevention Programme. 90% of those diagnosed with a type 2 as diabetics, and it is mostly preventable. We spend around about £10 billion a year in the treatment and care of type 2, well, diabetes as a whole, and I believe 8 billion of that on type 2. And every week, diabetes leads to 184 amputations, 770 strokes, 590 heart attacks, and 2,300 cases of heart failure. We've taken that from Diabetes UK. So preventing diabetes earlier can stop all of those outcomes from happening. So there's a few programs out there nationally. You'll have your own local ones. Each area has different local education programs out there. It's important at the moment just to point out that there is some shortages with medications for some type 2 diabetics. So really encouraging the education side of things while some people might be struggling to get the medication is a brilliant thing, and it's never too late. So if they are type 2, things like the Healthy Living app is available, a digital weight management program. So even if you are with someone and they are already diabetic, there are still options out there. The thing that we are talking about today, though, is prevention. So that's your pre-diabetics over 18. And there's very few exclusions. If they're already type 2 or they're pregnant, then it's probably not suitable. But other than that. Next slide, please. Thank you. So knowing what we know, that it's prevalent, that pre-diabetes is dangerous and that it can lead to diabetes, I've been looking at the data and saw a PCN in Wakefield, the one that I used to work for conveniently, that had some really good outcomes on referral numbers. So I had a chat with Paul, and I'm going to hand over to him to let him tell you how he's managed to do that.
Cheers, Elaine. Thank you. So yeah, I can share kind of what we do in our PCN at Trinity Health Group in Wakefield, and share kind of what we thought went really well, what we kind of learned along the way, which, to tell you the truth, wasn't actually the main outcome. I think when we talk around having these quality conversations, we kind of just learn when doing this, we can have much better conversations with people, not only get a really good outcome for the patient, but also the practices also get those referrals as well. And it worked very, very well. So yeah, more than happy to talk around with Wakefield. So David, if you go to the next slide for me, please. So thinking around what matters to you. So as a health coach, that's a very, very good question, central to kind of with what I do working with people. It's asking them questions around how they are, like how Caroline described, you know, how do I feel? We're very complex. There's lots of things that can interact with how we're feeling and also influence our own behavior. So what this basically shows is the majority of people are wanting in healthcare good conversations with people, getting that good, helpful information, having understanding, trying to have that empathy with people, and really listening to them as well. I think we're very, very lucky in our personalized care roles where we mostly have, hopefully, more time in our sessions compared to maybe practice nurse or a doctor. And it's how we're using that time. You know, if I can spend a lot of that time listening to the person in front of me, I can get a better understanding of how they're feeling. And as a health coach, how that can maybe influence their behavior. So having those questions to mind, like what do you actually want to talk around today? What's currently mattering to you? Like Caroline said, no one's going to go with type 2 diabetes. I need to know around how I'm going to take my medication. That might not be the most important thing to them. It might be at that time, but I've never had in my appointments, it's around, I need to know what I can do to help improve my health. So it's about empowering them. You know, how can we do that? So next slide, please, David. So for us, before I started, how it worked with the pre-diabetes in our PCN was to get that HbA1c result. The practice would send a letter inviting them to sign up to the diabetes prevention program. And I think that was it, unless there was any conversations in practice with any diabetic reviews or annual health checks. That was pretty much it. So it is all ownership on the person, on the patient signing up. However, we know we're complicated as human beings. There might be lots of things going on. There might be lots of barriers there. So when I started, the discussion was, okay, me as a health coach, where would I have the most benefit? And around prevention, okay, well, when we look at type 2 diabetes, metabolic syndrome, picking up newly diagnosed pre-diabetics is a great place to start. So in terms of how we work now in our PCN is the letter gets sent out, but I now, or another health coach in our PCN, follows up from that. And we just check, have you received the letter? Did you understand the letter? What sort of things are you thinking when you read that? Have you signed up? What are the barriers to you to signing up? It's just allowing that opportunity to have a good conversation with someone, to understand them and listen to them and try and help them get that best possible care. And again, it's shared decision making, isn't it? So we do that now just as general practice. Every newly diagnosed pre-diabetic is going to have a conversation with a health coach. And of course, with the read codes at the bottom there, we make sure that we code them. Next slide, please, David. So what we decided to do as we got another health coach involved was we saw that, well, we're increasing our numbers of referrals to the diabetes prevention program, and me being me was like, oh, I want more of that. That looks good. So let's do some proactive work, because we're picking up the newly diagnosed. But what about the people the year before? What about the people who maybe haven't had that conversation? So we did a bit of a proactive work in Wakefield, where we ran some reports on System 1, looking at the people who haven't been referred to the diabetes prevention program, and can we pick these people up? Can we look at backdating it and having these conversations with this cohort of people? So we basically just played, I called it playing call center. Not gonna lie, painfully painstaking it was, lots of phone calls, but it was great. We could feel the benefit, and the numbers speak for themselves. So that top left graph from 2022, is that the whole year, Elaine, isn't it? You can see that us as the pilot PCN, we made a lot of referrals, and I think partly probably due to how we work with, we will always speak to someone now first and offer that, but also we did that proactive project to play catch up really with the people who we didn't speak to. And then at the bottom you can see the improvements before we actually had these conversations and before we picked up these newly diagnosed pre-diabetics as well. You can see that the numbers just shot up, which is great. It means that we're offering this to more people, but also we're offering just a listening ear. There might be some other barriers in place, and that's what I'm sure that David will be really keen to talk around later on, is how our roles as personalized care roles can link with each other. Next slide, please, David. And then interestingly, Elaine shared this with me. This is following our project. When you look at the referrals by deprivation in the quintiles, the most deprived area actually saw a massive increase in referrals to the diabetes prevention program. We didn't target this at all, hands up. We didn't. We just basically decided, right, we're going to do pure volume of work, have loads of good conversations with people. Can we offer them that good care and maybe work with each other in terms of social prescribers and care coordinators more? But that's just a fantastic outcome, showing that by putting in this time and having these better conversations, we actually can reach people in the most deprived areas. And I look at that and think, well, okay, maybe why has that happened? If it's just a letter, what's the reading age of people in that area? Is that a barrier? Potentially they didn't fully understand, and having that conversation, I kind of spoke to our other health coach around it. We kind of acted a bit like a salesman, but it works. It's asking them around these barriers, it's getting them thinking around, okay, well, if you don't want to do this now, what's stopping you? And we work with loads of people from those conversations. So just to show that that was quite a nice effect really from the work that we put in and did. But that's pretty much it. More than happy to talk around the how we got the list and on System 1 the reports if anyone's got any questions for me. But I think Elaine, you was going to pick up the toolkit now, wasn't you?
Absolutely. So thank you, Paul. Really fantastic outcomes from the work that he's doing. And the question for me and our team was, how can we spread that wider? How can we get other people doing the same thing and having these quality conversations with patients? And what training or support might someone need to be able to do that? So what we developed between ourselves is a quality conversations toolkit for the NDPP. So if you'd like to give me the next slide, David.
I will do. And just to let everyone know, if you've got a question for Paul or for Elaine, there will be an opportunity to pick those up shortly.
So the Quality Conversations Toolkit initially was designed by a task and finish group. We had people from a few different areas, mostly in personalised care environments, come together to talk about it. And once we'd put a draft together, we reached out to various other groups to try and get some feedback. So we've had about 3 or 4 versions. I think we're at the final version now, but the feedback's been brilliant. Diabetes UK and Read have told us what the common barriers are. So we've been able to address things that personalised care roles might come across a bit more often. Next slide, please. So this toolkit essentially is an overview of the course and an overview of personalised care conversations and how you might be able to have those with the patients. For some people, it comes quite naturally. Paul is a fantastic salesman. He can pick up the phone and talk to anyone, but it's not always that easy for some people, you know. So a few prompts on how to start the conversations, what kind of answers you might need for certain questions. And I mean, no 2 patients are the same. We know that. So your first patient might have a question about the course location and where it is, and your next patient might ask you if you know who can look after the dog while they go. You know, you're never going to get 2 of the same questions. So it's about thinking about what you might come across and how you might address it, and make sure that the patient has got all the information that they could possibly need to make an informed decision. Even if that decision is to say no, at least they're making that decision based on all the facts, and that's important. Next slide, please.
Just to butt in with that, Elaine, as well, from doing the work and just from continuing these conversations that we have, you'd be surprised at the amount of people who turn a no into a yes once they know they can access it from home. It's surprising. Again, equipping us with the knowledge of this is what the program looks like. We can give them all the information. It just leads to better outcomes.
Exactly that. So the audience for the toolkit, to be honest, it's basically anybody. We have designed this with personalised care roles in mind for social prescribers, your care coordinators and your coaches. But realistically, if a practice has got an admin person with an interest, there is no reason why they can't be having these conversations as well, or even VCSE sector staff. Everyone, the more people that know about the NDPP and can talk it through with patients, the better. It's really not got a limit in that respect. Next slide, please. So I'm not going to show you the toolkit slide for slide because it'd take me all day, but I'm going to show you roughly what it is included in it. And obviously, again, the caveat is West Yorkshire based, and this is based on Read Wellbeing. So there will be slight differences in other areas. So the toolkit has got some really detailed information on the programme, what the eligibility criteria is, what special the tailored remote services are available for other languages or for the visually impaired or hearing impaired patients, and what the sessions include. So there's 13 sessions. It is spread over 9 months, which can sound quite intimidating to a patient. You're giving up 9 months of your time. However, if you pitch it as 13 sessions, it does sound a little bit nicer. You have a 12-week session with your weight management courses, so it's not hugely different. And it just sounds a little bit nicer. So we have noted that people prefer to be told 13 sessions than 9 months. So the first few sessions are fortnightly, and then after the first 4, I want to say 4, it might be 6, Sonia, correct me if I'm wrong, it moves to monthly after that. And what's important is the group that you join, you will stay with for the whole 9 months. So the peer support starts from that very first session. You've got other people in the same boat as you, and you build the relationship with your peers alongside your coach that runs the sessions. So you'll take the journey together, and it's been proven that peer support improves outcomes. So it's always going to be beneficial. There is also the digital option, which comes on an app. And this app can be accessed anytime, anywhere. So for your patient who works shifts or has childcare or cares for parents and just cannot give the time to go face to face, this digital option is perfect. And you get lifetime access to the app as well. So it's not like you get your 9 months and then it cuts you off. So frequently asked questions. This has been developed with Read, and they've told us what sort of things a patient might want to know when you give them a call. So how long it lasts and why. So the why is because with behaviour change, it's not going to change overnight. So you need the 9 months to really implement those changes and to be able to continue it after you've finished the course for the rest of your life, essentially. Some people might worry about the mobility. They don't want to go and run laps, or if they've got other commitments, again, the smartphone app is a brilliant option for people of working age or with other responsibilities. Next slide. So working with Read, one of the biggest barriers that we came across was that patients who have been referred didn't often answer the phone. And this potentially is because the phone number that Read call from is not the surgery number and people don't recognise it. So a very simple step right at the beginning with Paul when he's talking to our patients is to give the patient the phone number that Read will be ringing from, save it in the phone, and then when they contact them a week after their referral, they know who it is, they're expecting the call and they're more likely to answer it. And it's so simple, but it makes such a difference for the patients. Next slide. So in the toolkit, we've got video resources. Don't think we need to play any today. I don't think we've got the time, unfortunately, but they are available on YouTube and on Read Wellbeing's website. You'll find some case study videos and some videos on what matters to you. But I'm sure you'll have seen that. And again, unfortunately, just to skim over, because I know it's not going to be the same in every area, but how to refer is included in the toolkit as well. So if you sat with a patient in a clinic and you see a green triangle on the screen, even if they're there for a different reason, that can trigger in your mind, this patient's eligible for the prevention programme. So let's have a conversation about it while they're here. And some tips on introducing yourself on the telephone to build some trust up with the patient quickly in order to open up that conversation. Next slide, please. So when you're in a personalised care role, these are the things that you're going to come across all the time. And for someone who's not as experienced, it's useful to be able to get some guidance on what you might expect. I'm too busy for this. I'm sure that that's the first most obvious one. People have jobs and responsibilities, and 9 months does sound like a long time. But does that person have permission to look after themselves? Usually someone with a caring responsibility, they put themselves last, and they just need someone to tell them that it's okay to look after yourself as well. And by giving them that permission, it might make them think, actually, I do need to look after myself, because how can I look after someone else? Anxiety and I mean, it's common. We have these common mental health problems now, and it's sometimes that mental health affects your physical health and the other way around as well. So what support out there is there? If someone has anxiety, are they getting support for that? If not, can you signpost them? And this is the great thing about social prescribing, is that when someone's highlighting other issues or barriers, is the ways you can support them through those barriers and get them to a position where they're able to join this course, which is something that Paul does working with his social prescribing team. Next slide. So again, research from Read has told us that the most common answer is, I know everything there is to know about pre-diabetes, and that is something that they come across all the time as a reason for why this person doesn't want to do the course. And that's fine if that patient has got facts and what they know about the pre-diabetes is correct, because the internet, unfortunately, opens the door to lots of misinformation. Google is great when it works, but not so great when you're finding out things that aren't fact. And a few times I've come across patients that think they know something about diabetes, but actually it's a myth. Diabetes UK have some great myth busters on their website if anyone ever wants to go and have a look, and that'll tell you some of the common misinformation that is shared. So that is one thing, making sure that what that patient knows is the truth. And if they do and they still don't want to do that, absolutely fine. NDPP is not for everybody, but at least, again, making sure that that decision is made with all the right information. Next slide, please. So barriers. This is something that it will vary depending on where you live in the country. It'll vary based on the affluence of an area or the deprivation levels of an area. So we're given some generic barriers, but again, there'll be more than what we've got in our toolkit, and it can be tailored if you were to have your own toolkit to suit the area that it's in. So we know that they do tailored remote services in other languages. These are done on Zoom and they are national. So although you will be in the same group throughout the course, you might be with people from other areas of the country, not just local. So that's something to bear in mind. We have recommended women-only sessions after some feedback, and that is something that Reed are working on. And when you're having these quality conversations, using language line to making sure that the patient really understands the information that they're being given is really important, because you can't give clear information if someone doesn't understand what you're saying. So we really do encourage using language line or whatever service your practice uses when you're trying to have these conversations. We know that people from a South Asian background are at higher risk of type 2 diabetes, so it's really key that these people are offered the support early. Sorry, Sonia, it's on Teams, not Zoom. My mistake. I prefer Teams anyway. So practically on this course, what are people going to expect? Are they going to come in and get weighed in front of 30 other people every week? Are we going to have a scoreboard on the wall? Because nobody's going to want that. No, you're not. And that is something that the patient needs to know. Are they going to be accessible? I've had a patient before who wouldn't go to a group because she didn't know where the toilets were or if they were going to be accessible, and something that simple was stopping her accessing education. So being reassured that the venues are accessible, that there will be toilets available, something simple like that removes that barrier, and she was able to attend. So being able to tell that to your patient will make a difference for some people. And it doesn't have to be face-to-face. That is the one thing. So people being busy can use the digital version. You'll get all your equipment given to you, and for visual and hearing impairment, there's options available. And quite key, if you need to bring a carer to the session, you're absolutely fine to do that. Some people with mental health problems or learning difficulties might find that taking the carer with them gives some support emotionally and physically and practically, and that is absolutely fine. Next slide. So again, no expectations to run laps. You're not going to crash diet, and no one's going to be measuring your pace against everyone else. What this is about is making small changes that you can stick with for the rest of your life, and it's going to happen at your own pace. And everyone needs to know that if they are nervous about these changes and what challenges they might face, that everyone will be in the same boat at first. And if it isn't for you, that's absolutely fine. But if you try that first session and see how you feel about things, it may be that digital is better and maybe it's not for you, but it's important to try. I think when it comes to your health, to try and avoid all those complications with type 2 diabetes, it is important to at least try. Next slide. So the toolkit gives some additional resources. Where we are in West Yorkshire, we have something called a CDEP licence, which gives us some training on diabetes. Reed given us some NDPP specific training, and there's loads of videos on YouTube or on our website. So this is an opportunity to share that with our teams in West Yorkshire to be able to look into things further.
Just conscious of time, we're just starting to run a little bit over, but I just want people to have, if people have got questions, this is going to be an opportunity for questions shortly, and I do want to allow a few people to ask some questions. So just a couple more slides, I think, and then questions if you want. Thanks, Elaine.
No problem. Thanks for that. Yep, next. Fab. So I think this might be my last slide. What happens next? So the Quality Conversation Toolkit has been developed in West Yorkshire. I feel like it's something that can be shared wider with some tailoring to make sure that whatever service it is that's in your area support you with their technical details. And actually Quality Conversations happens with a number of different things. So yes, diabetes, but also CVD and blood pressure, carers, smoking cessation. It could go anywhere. So what we're going to do is take it to a peer support network to try and find out where they feel the next topic would be of most benefit. It's also going to be put on the NHS England Futures page, so the people will be able to access it. And looking at Diabetes UK making a standard template for the NDPP specifically, so they can share it nationally. And that, I believe, is the end of my presentation, David, just in time for Q&As. Thank you.
Yeah, really great. There's one question in the chat about some data that was gathered around the barriers. I know you've shared some of the barriers. You might be able to pick that up in the chat. I think it's just where's that sort of source of data. Any other questions? If people do want to put your hand up, or if you want to drop us a line, yeah, hand up there. Is it Keaton? Is it Irvine?
Yes, it's Keaton, sorry.
Hello, Keaton.
Hi there. It's really fantastic work that you're doing, and I actually asked that previous question as well about where could we access kind of the data about the main barriers that have been gathered, because I think that data would be really interesting to just read through and just be mindful of as practitioners of what barriers people are facing day to day. Also aligns really closely with the research I'm doing at the minute, so it'd be great for me to see that. My other question is about how you plan to kind of evaluate the effectiveness of this toolkit. Have you kind of been forward thinking about how you might measure its effectiveness, or evaluate if it needs to change or improve or develop in any way as it moves forward?
Yeah, so I'll start at the first question there for you. Most of the data gathering has been anecdotal from speaking to patients, and I actually attended the course, the first session of a course, to try and gather information from a patient who just started on how they felt and what barriers they had. So it was seen firsthand, and then gathered from Paul's call centre project, which I think we spoke to about 400 patients. Is that right, Paul? It was quite large. Yeah. And obviously that is all based on West Yorkshire, Wakefield specific data. And working with social prescribers on the common barriers that they face mostly. So I don't have an actual report I could share, but I'm sure I can pull something together. That's not a problem. And second question, so with the toolkit in West Yorkshire, we are monitoring, we're training it out physically. So we're not just sending it to people, it's being trained out, and we're monitoring where that's being trained out. And then every month we get the data from Reed to tell us about how many referrals and how many of those referrals have converted to a patient actually attending. And we're expecting to see the quality of the referral improve, so the people actually attending the course. The target from NHS England is 50% of referrals to attendance, and I think we're running at about 66 in Wakefield. I can double check that, but I'm sure it's about 66%. So we've seen the quality improve, and then we're monitoring specific practices that have been trained and their referral levels. That makes sense.
Super. Thanks, Elaine. I can't see any other questions at the moment, but if we do want to ask questions and discuss in small groups, you will have a facilitator in the breakout rooms shortly. So really interesting presentation from you guys, and I suppose just what great impact you're having looked at that table there. There's always nice little bit of healthy competition when you're sharing between PCNs the number of referrals that they've made. So to kind of see the pilot and the difference between the pilot, well, fantastic work there, Paul and Elaine. Thank you guys for sharing that. So we, as Paul mentioned, we do want to think a little bit about how this offer with health coaching in the personalised care roles, how it sort of links to some of the other personalised care roles, as Caroline was talking about earlier. There's that interconnection between the care coordinator, the link worker, and the health coach. Obviously, not every PCN has all three roles, but we do want to try and think a little bit about, how we're working together. So the next section is really going to spend a little bit of time listening to colleagues from Calderdale. We were expecting one of the link workers, Nabila. Unfortunately, Nabila was unwell today. So luckily, Ella has already done a pre-recorded set of slides talking about her experience and her research with the team in Calderdale. But, just to sort of say thanks to Ella, who is currently sunning herself, probably drinking a cocktail. She mentioned she might be having a cocktail or two while she's on the beach. but she did send her regards, and just to say thanks very much for taking the time, Ella, if you are watching this back. So let's hear from Ella.
Hello everyone, this is the third time I've tried doing this recording now. You'd be amazed how you think it's going okay in your head and then you watch it back and you realise you sounded absolutely awful. So it's a bit weird not being there today, albeit in a virtual capacity. I am on my hollybobs, currently sunning myself. So that's why you've got me in this pre-recorded sense, which is strange because I can't interact with you. However, we're going with it. So let me introduce myself. That might be helpful, mightn't it? So my name's Ella Fairbrother. I've got a couple of slides to share with you, so just let me get those up. I'm one of the personalised care team leads in Calderdale. I look after a lovely team of social prescribing link workers and care coordinators in the lower Calder Valley. I thought it would be good to kind of share the current picture of things in Calderdale's personalised care team in relation to where we're at in terms of NDPP referrals. What we know is that our team feel very comfortable referring to our local weight management service, whereby in the first instance, patients are offered Slimming World vouchers, or perhaps a one-to-one trainer if they feel their needs are more suited to that particular style of support. We've realised from doing a survey, which I'll share the results with you in a moment about that our team are lacking a bit of knowledge and confidence about making referrals into the NDPP. So I just wanted to share with you how things are now, what we're going to do about it. Might give you some ideas, hope it does. So the current state of things, it's a little bit bleak, but don't worry, we've got a plan. So how things are looking now, 70% of our social prescribing link workers, I'm not going to keep saying that, it's too much of a mouthful, SPLWs, had heard of the NDPP, 30% had not heard of the NDPP. 30% of SPLWs knew how to refer, 70% did not know how to refer. Interestingly, 90% of the SPLWs had never referred to the NDPP, 10% had made a referral. When we started having conversations and looking at when asked why the SPLWs had not made a referral, 10% said they just didn't have any eligible patients. 50% stated they were unsure of the qualifying criteria. What a great bit of information, because we can do something about that. We can make sure the team know about the qualifying criteria. So that's such a good bit of info. 10% stated they'd referred on to our local weight management service, and 30% gave another response. Also, another really good bit of news is that 90% of the team wanted some training in order to understand the referral criteria and the process and what the NDPP is all about. Only 10% felt they knew how to refer and didn't require further training. I think, as you'll see from the toolkit, there's a little slide that it recognises Calderdale as the lowest. I think it was in the West Yorkshire region. In terms of referrals to the NDPP. So there is work to be done, and hopefully our Calderdale's personalised care team can make an impact on that. So what does the future look like? Well, has anyone seen Guardians of the Galaxy 3? I can't interact with you, so this bit's weird, but I've got a newfound love of raccoons, although my husband says we're not allowed one. He's not being very supportive. But when I saw this little meme, I was like, oh. Moving forward, we are going to be doing some training with our Calderdale-wide personalised care team in October, and that's going to cover the referral process, the criteria, and the amazing use of the amazing toolkit. Elaine and Laura, who are on the call, along with Adele Brayton, have been very helpful in ensuring that I've got all the correct information to be able to deliver this training to the team and help build their confidence and knowledge around the NDPP. Obviously, the benefits of doing this training, it's going to increase patient choice, isn't it? And personalised care. And the benefits to the practices. So obviously they receive a payment for each referral to the NDPP currently, and also further cost savings if those patients are prevented from becoming diabetic. So further cost savings. So wins all round. And you know, we hope to be able to for our social prescribing link workers to do sort of opportunistic referrals, you know, looking in the patient record, are these patients eligible? Yeah, I'm going to have a conversation with them about that. There's also potential for targeted work, you know, building searches in the system, looking at how we can target patients more specifically. And again, that will help increase these referrals. I think that's enough from me. It's the third time I've done this recording. I think that's enough times. I'm not going to watch it back again because I'm just, don't like listening to myself. I've provided my contact details on the first slide in case anyone wants to reach out and connect. So that's there. And hopefully when I come to ask the team the questions again that I asked on the second slide, hopefully we can show that that knowledge, that confidence has increased and our team feel more comfortable and confident in making those referrals and having those conversations about the programme. So thank you for listening. Enjoy the rest of today's session. It's going to be a good one. And yeah, take care, everyone.
Well done, Ella. I think that's really great. I'm just going to stop sharing a second because we want to also bring in a colleague from Wakefield, following on from Ella, really talking about her team's perspective. It'd be great to hear from Callum. I know I can see Callum on the call, so thanks very much for your time. As a link worker, Callum, hopefully can spend a little bit of time just expressing, you know, how you've supported patients around your weight management. Of course, I know that there's like a high waiting list for weight management services. So could you tell us a little bit about your experience of working with your health coach and potentially what you think about this program?
Yeah, absolutely. So yeah, as you touched on in Wakefield, it's been difficult, you know, and it's hard when you get a referral coming through for weight management and trying to manage that, and knowing that the main local services have incredibly high wait times, and then trying to manage that expectation then of, you know, how can we think broader and what other sort of community groups, as it's been touched on previously, are there for support. So me and Paul have been thinking, and you know, trying to do some work around how working in a PCN and working alongside staff like Paul and previously Elaine, when she was a care coordinator, the approach being quite linear as it's been described from primary care to social prescribing, and it never really seems to go back. So now we're trying to make a shift where I'm trying to build my knowledge of obviously Paul's offer and the offer from the PCN, and further obviously what we're learning about today, the prevention program. So it's just been really helpful to come along and learn about what's offered. So this, you know, as a link worker, is something else that I can put in my own toolkit to give to people. So when these referrals come through, I don't sit there with my head in my hands going, I just don't know where to send them. I just don't know what to do. So obviously learning now that understanding Paul's role more and working closer with him and understanding what the offer is from Elaine as she took us through has been really, really helpful. And it'd be good to feed back to the team as well on what the offer actually is.
Brilliant. Yeah, thanks very much. It's really interesting as a, you know, background in link worker sort of role. You know, it was often difficult to understand some of the referral processes and criteria, which obviously was picked up in the research that Ella's run, and to hear your perspective as well there, Callum. Thank you. We're going to spend a little bit of time now in the breakout room just discussing in some small groups. Really, there's a few questions that we'd like you to think through, which I'm just going to put on screen. You will have a facilitator in your breakout room, but you may want to take a screenshot or a photo of those questions just to remind you of the things that we're going to be talking about. We have a few minutes allocated for this. We're hoping to come back together in the main room at 4:20. My colleague Tom has been working feverishly behind the scenes to allocate us all to breakout rooms. So credit to Tom for that. I hope it's all going to go smoothly. And the plan is to be back just over 20 minutes. So fingers crossed, Tom, you can launch us all into hyperspace now, and we'll all end up in a breakout room with the facilitator. Oh, wonderful. I can see that I've got my join room. Okay, thanks very much. We'll see you all shortly. Hello, everybody, and welcome back. You are being recorded again. And just to say how fascinating, I really, really enjoyed the discussions I was having in our breakout room. I'm going to put everybody on mute. Welcome back. In terms of the next steps, we do want to hear a little bit of that feedback, but we also want to give you a chance to talk about, how you feel yourselves. So the way we're going to do that is we're going to allow a bit of Mentimeter. So we should see this popping up on screen. And the way that I want you to contribute to the Mentimeter is by using the link that's now in the chat. You can join Menti by going to menti.com and using the code at the top, which is 49968908. Just to tell us about how you feel about the toolkit now would be great. In terms of some feedback from my breakout room, it was actually really interesting that not everybody in that room knew about the referral process or the ability that they were able to refer. They thought it was clinicians only who could make referrals to the NDPP. One colleague actually shared that they had the triangle, I think the green triangle, in the system 1, and they were in the Humber North Yorkshire area. And another colleague in another part of the region as well said that they didn't have access to that on EMIS, so it wasn't really clear and easy for them to be able to identify who was eligible for the referral to the NDPP. So that was a couple of bits of feedback from our breakout room. Lots of people saying that they really found it useful and took a lot away. So thanks to Lane and others for what you've shared today. And Paul, yeah, really interesting. Just interested from other people's breakout rooms. We've got a few people on the call. We've got Newman as well as Caroline, Laura, Elaine, Paul and Sonia, who might be able to share a little bit. So Newman, if I could just come to you, is there any key points you want to share from your breakout room?
Yes, I think one of the key finding was there, the information, available information to health coaches, how they can refer people to NDPP wasn't available until today. Some of our coaches didn't know this was a program available to everyone. So that was one of the key finding. Of course, also another question was how it benefits them.
Yeah, yeah. Thank you.
So finding that. So yeah, that was 2 key findings for me.
Wonderful. Thanks so much for feeding back. I really appreciate your thoughts. Look at that popping up on screen. 36 responses, useful, beneficial, helpful. Some really positive comments from everybody talking about their how they feel about the toolkit and just general experiences. I wonder if I could come to Caroline as well, just while I move on to the next question. Caroline, from your breakout room, anything that you want to feedback?
So we were quite a small breakout room. A couple of people had to dip out to go and see patients, but so out of the 7 of us who were there was 4 people were pretty much new to post in the last few weeks, which was really interesting in itself. But they were all saying that it was really fascinating and really useful information. We're very grateful for the presentations that the team had shared today, and that they find the information really useful with their patients.
Great. Fantastic.
Yeah.
Thank you.
Okay.
I'm going to ask, thank you so much, because I'm going to just try and bring everybody in. We've got Laura and then Elaine. Laura, any things you want to feedback? And just to say, we would like to gain your insights onto this question here in terms of, would you like the quality conversation training in your area? We can't guarantee that we can fund the training across the whole of the North Eastern Yorkshire area, but if lots of people want it, we've got a better chance, is what I would say. Laura, would you like to add anything?
Yeah, so we had a group that was quite mixed in different roles and different areas. I think it was interesting to know their experiences. So everyone reflected and thought that actually they'd probably had patients that they could have referred into NDPP had they agreed, but didn't know about it, so hadn't. So I think there's definitely recognition there that lots of people that potentially have slipped through the net in the past and obviously won't going forward, which is wonderful. And in Darlington, there's a PCM that's already looking at doing something similar, which is wonderful. So Elaine, they might be reaching out for some support of our learning, which is fab. And I think just that training and in terms of people knowing and pitching it in the right way to be able to convince someone else it's a good thing to do.
Yeah,
was the key message from our group.
Wonderful. Thanks very much, Laura. And Elaine, if I could come to your breakout room, any key things that you want to feedback? And just to say thanks everyone for your Menti results. Really great to see so many yeses there.
Yes, one of the feedback, the most important feedback we got is that some of my group who are not from Yorkshire don't know who their provider is. So in the chat is a website and it's got every area and who your NDPP provider is. So please, if you don't know, have a look, because that is the number one most important thing, is knowing who we're referring to. My group currently work with diabetes cohort, so already past the stage of pre-diabetes, but they didn't know about the NDPP, so it's always useful encountering maybe family of patients who are pre-diabetic. You never know who you're going to bump into. And Georgia from Leeds was really enjoying sharing, learning, and how social prescribing works up in Middlesbrough, and how the structure is and how Leeds can take things from them. So it was nice to see the sharing of processes.
Thank you so much. Really interesting to hear your thoughts, and great link resource to be shared in the chat. And we'll make sure that gets sent out as well with the slides if it's not already on the slides. Certainly helpful to have your points there. Thank you, Paul. And then Sonia. Paul, hi.
Hello. Yeah, it's pretty much just echoing what everyone's already said. I think the information is the big thing there. Information around how to refer, what the program consists of, where are these locations and how else can you complete the program. It'll just be a really good, give people the confidence to actually refer a bit more. And then also in the chat as well, just having a plan. Having a plan if you're working in the same PCM, what sort of plan can you put in place? Obviously do the opportunistic, but how ways can you actually reach these people on a greater scale? And I don't know if Newman mentioned around what's the benefits to as in the practice side of things. One thing that we did record is with the NDPP referrals, that's under the weight management DES contract, so there's payment to that. If you can showcase practices, you've generated this money for the practice, that's brilliant. But personally, what about the person cost? You want to help these people, prevent them developing type 2 diabetes. That's worth more money than what the practices get as well. So just to reflect that back.
You can see why he's such a good salesman, can't you?
Oh,
really?
Absolutely.
Brilliant. Thanks, Paul. And if we could go to Sonia as well. Thanks.
Yeah, so I don't think I can add much more than what's already been said. My group had a couple of newer coaches who were really looking to learn a bit more today. Lots of questions about how to refer, what the NDPP actually is on a bit more of a detailed level, where the venues are, also how to find out who the provider is. So pretty much everything that everyone's already said.
Thank you. It's really great to have all of your comments, and just interesting about what support people might need to embed this process to increase referrals. Yeah, great. See so much interest in the training, and that one point for me about Paul in terms of saving that phone number. So when they do receive that call, they're more likely to understand and not block it. I think is a great bit of learning. Thanks so much for everyone's comments. I'm really conscious of time, so what I'm going to do is just highlight that there's going to be some further links in the slides. We're going to add in the slides from Caroline as well, and you will receive that information shortly. In terms of evaluation, I would really appreciate it if you wouldn't mind just taking a couple of minutes to complete this evaluation. I hope Tom might be just dropping that link into the chat box for you now to click on the, thanks Tom, the link for the survey. If you want to use your smart phone and scan that code, you can get some feedback that way. And I am really conscious of time, and we're pretty much right up to the minute. So thank you so much for taking the time to join us for this webinar. My colleague Keaton is on the webinar with us, and did mention earlier that she's doing some research around diabetes. And you know, I am really sorry that we've not had time to give you the space to talk about that, but just to let people know that, you know, when we send out a follow-up email, we'll attach the slides and just give you a little bit of information about what the research that Keaton's trying to do across the region. And please do get in touch. Whenever you're running research, you always need participants, so please do give that some attention when it comes out. Okay, just to say thank you again to all of our facilitators and speakers, and just to everyone who's contributed to today's session.